Recording's just started.
Lovely, thank you. Okay, so I make it 1:30. So great to see everybody, and welcome to all those who have joined to listen or to contribute. My name's Debbie Bartlett. I'm a member of the ICB, and I'm the Director of Adult Social Services for Norfolk, and I'm the chair of this Primary Care Commissioning Committee. So I'm hoping you're going to be kind and gentle with me today, because it is the first time that I've chaired this and it's a bit of a new agenda. So please don't hesitate, Sadie and others, to come in and give me a nudge or correct me. Hein, your experience will be invaluable as well. So please don't feel precious. Just give me a nudge. Okay, so with that, I think we've got some apologies. Sarah, are you going to share those, or do we take those as noted?
Yeah, I can confirm I've got Andrew Haywood, Jason Stokes, Mel Benfell from the LMC, and Tanya Farrow has confirmed. Apologies.
Lovely, thank you. Perhaps I could just add Bill Borrett in those apologies, please, who's on leave. Okay, all right, that's great. Thank you very much. So that takes us then on to declarations of interest. Are there any declarations that people, specific to any of the items that people need to declare? Yep, looks as if we're all right. Lovely, thank you very much. Okay, so that then takes us on to the minutes. So our last meeting was in July. Here we go. So I wasn't necessarily proposing to go through those page by page. Are people content that this is an accurate record of our meeting in July? Okay, well, could we have someone just to sort of formally propose that? And maybe people have got their microphones off. Okay, we're content with that, are we, Sadie? That's okay for everybody to nod?
Yes, I'd say that the voting members of the committee, Debbie, are yourself, Karen, who's representing Tricia Dorsey, yep, Stephen, and Hein.
Brilliant. All right. Okay. We'll take those as read then. Thank you very much. Okay, that's good. So that takes us to the action log. So we had some that were yellow on the action log, which I think perhaps means we need to have a look at those. Sadie, is that right?
Yes, so we've Sarah has very helpfully marked the due dates for us on some of those. So the first two will remain open, they're not due until September. Action, oh, I seem to have lost my, there we go. Action 153 is complete. Sorry, 154 is complete. Action 155 has been added to the forward planner, so I think we can close that. As yet the date is to be confirmed, but it's listed there. Okay. Action 156 has been added to the forward planner, so that can be completed. Okay. 157 is already marked as complete. 158 is added to the forward planner, so complete. 159 is coming to the October meeting, so that can be completed, and the final two are already complete. Thank you.
Okay, all right, that's great. Thank you very much. That's really good. So that takes us on then to the first substantive item today, which is about the care market quality assurance and monitoring. And Who am I handing over to Karen for this, or am I handing over to Paul?
It will be Paul, I believe, Debbie. We've skipped over the forward planner. Are you happy for me just to go back to that?
Oh, yes, please do. Yes, sorry. Thank you.
Thank you. So hopefully people have had a chance to look at this. It is now looking quite busy. Sarah has helpfully included all of the changes. They're highlighted in either yellow or red or both. And you can see that a number of the dates are still to be confirmed as we work through splitting the business across the operational delivery group and the committee, so that we can ensure that the committee is only dealing with either the system level strategic issues or those of high value or high reputational impact. So I don't propose to go through it line by line. The only things I would point out for today is that you'll see that severe mental illness health checks and the health check stocktake report, which were due to come today, are both highlighted in red because those were agreed at the last meeting as now being on the operational delivery group agenda. So I have put this on here for approval. It would be really great to have any comments if people have any concerns or if they notice any gaps. But while we are going through this process of transition, there will likely be changes every month to the forward planner for now as we start to shape everything across the two new forums.
Okay, all right, thank you, Sadie. So I think James wanted to come in.
Yes, thank you very much indeed, and good afternoon to everyone. Could I just understand why the dental short-term plan has been moved from September to October? I'm sure there's a very, very good reason, but it was due for September, was it not? Due to the urgency of dental care throughout our area?
Thank you for spotting that, James. We had meant to move that was on October by mistake, and we had intended to move it to September. So you're right to point that out. The plan is still to bring it in September.
Thank you very much indeed. Thank you.
Thank you. Anything else anybody wanted to highlight on here or comment on? Fine.
Thanks. The date for the performance report is to be confirmed. I just hope it's not many months away from us, because I think several members, including myself, are eagerly awaiting it.
Yes, this is linked into the work that the BI team is doing following the audit report, which we talked about last time. Shepherd, I don't know if you have an update on this. I know that they were working on it and we were planning to phase it in, but I'm not sure exactly when we're starting, so I might have to hand over to Shepherd for that.
I will have to follow that up, Sadie.
Yeah, I would just encourage that perfect not be the enemy of good. So yes. Happy to start somewhere and then over many months we'll improve it. But yeah, thanks.
Okay. All right. Otherwise, then helpful to see it set out like this, and just acknowledging, you know, what Sadie says as the two sort of the working group settles into its role as well. There probably will be a little bit of jiggery pokery around this, but for now that looks a really comprehensive list. So thank you very much. Okay. Okay, so that does take us on to the item about care market quality assurance. So Karen, am I handing over to you for this?
I believe you're handing over to Paul. Has Paul been called in?
I'm here. Good afternoon, everybody.
There you are. Sorry, Paul.
Welcome, Paul. Thank you.
We'll do a double act.
Thank you.
Fantastic. Yeah, that's
okay.
Great.
I can see Paul. So can everybody see? Can everybody see
Lovely.
that?
Yes, we
Lovely.
can. Thank you.
Lovely.
Thank you,
Okay.
Karen. If you just skip forward to the next 2 slides, then we'll go to the first slide. So thank you very much. So what I wanted to do this afternoon was just give you a brief overview of the current governance arrangements for the care market sector and how we're sort of monitoring and providing assurance in this area. What I will say is that this is a current picture. What I'm looking to do over the next few months is to improve this slightly and get more reassurance and how we work differently with other providers and with system partners, and more importantly, where we work with place and how we work with place. But I think the current sort of structure is aligned with the head of integrated quality services working for the local authority, and they also provide the strategic direction of all the formally the policies, etc., and the procedures. And of course, they have underneath them their quality monitor officers and the senior quality monitor officers, and the team of quality improvement nurses who currently work with myself at the ICB, who've been around for some time and have got vast amounts of experience of working with lots and lots of providers in this field. So that's currently how it works. Go to the next slide, please, Garen. Thank you. So how does it work, and how do we provide that oversight and scrutiny? So we have something called a PAMS tool, which has been designed by the local authority, but obviously has had input from the team who work with the current CQC regulations. And of course, what we do is we go and do a joint assessment of the care homes that we are aware of, and I'll come on to how we are aware of them in a moment, who are either falling short or we're notified of an area of concern. Now, the local authority, of course, commission all the services for the care providers themselves. And of course, we'll obviously doing quite a detailed assessment when we get there. But this is only at the moment currently based on risk. So what happens is we either get notified by the CQC, or we're told of an area of concern from primary care practice, or we've been out and done a PAMS assessment ourselves. And whilst we are hopeful that we capture all the sorts of areas of concern directly, we know there is a gap, and we're not getting to everywhere where we need to because of a finite resource as well. So the quality improvement nurses, they support the PAMS visits by providing their expertise on the health related matters, not just on regulatory elements as well. Next slide, please, Karen. Thank you very much. So the function of the quality monitoring visit that we actually have is basically just having that kudos visit of sort of the sense check of what's actually happening. We also use the actual visit to follow up on actions that have been left outstanding from a CQC report. Have you making good progress in this field? For example, if medicines management is an issue, have you caught up with all your associated actions? And that's the thing that we're finding at the moment. And of course, what's your workforce plan looking like? But also it's about having that copper's nose on the actual ground, looking around what's happening, making focused inquiries in response to any concerns have been raised. And of course, the nursing elements that team provide are therefore sort of subject matter experts, which is providing quite a robust challenge to those answers as well. If you go to the next slide, please. What I want to do is just to show you a brief example of where we are since January this year. And you'll note there has been a slight improvement in the ratings of the providers across the patch. Now, what I will say is this is not just down to the turnaround of some of the CQC inspections that we've been doing in the PAMS visits. This is also making the decisions that were to close some of the homes who have never actually made a dramatic difference and a dramatic improvement. We've taken some tough decisions here. However, despite all that, and since the pandemic has pretty much concluded now, we are seeing a turnaround, albeit slow. There's a long way to go in some of the ratings improvements since the pandemic. So it's really, really encouraging to see. It's like turning an oil tank. It will not happen overnight. However, we're making good progress. So I'm confident that will continue to improve as we take those difficult decisions as well. Thank you, Karen. So how do we escalate sort of concerns? Well, we get feedback from a lot of primary care surgeries. We get a lot of feedback from the clinical teams that go into these homes. We also have a provider meeting forum. We have a quality improvement notice, of course, and notifications from the providers themselves to say that they are actually struggling. So there's several ways that they currently feedback and escalate concerns. What I'd like to do later on in the actual next rendition of what we're trying to achieve is improve that and really strengthen that process of transparency with the providers, which will make it a lot easier for them to contact us and share their concerns as well, which we're not quite there yet. Next slide, please, Karen. What we're sort of making changes to at the moment is we are reintroducing something called SharePoint, which some of you may be familiar with, which happened over the 2 years during the pandemic. We're calling this the Care Market Quality Forum meetings, where we have a lot of membership from place-based leads, clinical leaders from different providers across the patch, NCHC and EC, for example, people who are often going to the care homes and are able to share their concerns with us. So we have that informal conversation, but with the right governance in place to make sure that we have the intelligence to act upon fairly and robustly with the right amount of information across the whole of the actual region. So that's being reintroduced. Not quite there yet in terms of the actual terms of reference, but that will be starting very soon. So the next slide talks about how we improve. And, you know, from the quality improvement nursing point of view, and even from a county council point of view, training isn't actually part of our role. But what we do is we facilitate bite-sized learning and champion sessions from across different providers who already work with the Enhanced Health and Hair Framework, which you'll all be familiar with. Now, we've had lots of success stories with this over the last couple of years. The University of East Anglia invited several care homes who were rated good and above to be part of an improvement programme for the care market and receiving lots of awards as well through their robust work they put over the pandemic and improvements into their net care they provided for the residents in that region. So we've seen lots of improvement across the patch in those areas. And it's been a real boost for the care sector, especially if they've gone through a very difficult period of about 3 or 4 years. And how we're looking at measuring improvement as a whole is looking at reduction in falls, call outs from the ambulance service, hospital fire infections reductions, medication errors, etc. All those things are how we look and base and categorize improvement. So next slide talks about how we've introduced a champions network, which has seen significant improvement in some care homes. Actually, the CQC have referenced lots of these improvements in their reports, which has been a great morale boost to those individuals who work in that sector as well. So huge encouragement for those care homes who have been part of that work. And I just want to talk about how we support admission avoidance on the next slide. There's several areas which we believe that we can focus on, which will make an improvement. And I think the market line is that we want to make sure that we're not in a similar position to what we were over a year ago, with the admission rates in the acutes really, really high. So where we've targeted our area of admission avoidance this year will all be around falls, end of life, catheter care, skin and wound care, nutrition, hydration, oral care, epilepsy, signs of deterioration, when to ask for help, for example, sepsis and bowel care. And there are lots of programs ongoing at this moment in time, working with IC24, working with eEast, and also looking at how we can really plan and manage that unscheduled care across the whole of the system. And Knowledge Anglia, on the next slide, is our database where we put all the information to be accessed by care providers, make sure they have the right help at the right moment in time going forward. Right, I'm going to pause there. Actually, there's a few more slides, which I'm sure you've all seen. I'm going to pause there and I'll probably spend a better time in conversation about discussion around any questions, if that's okay. Thank you, Karen.
Great, Paul, thank you. So, you know, an absolutely critical part of the health and social care system, and one that is, you know, historically perhaps been a little bit taken for granted or overlooked. So really glad to see it on the agenda here. And would also just want to say how, you know, I think we should be proud of the integrated approach we've got to this across health and social care. You know, the quality ratings of our care providers in Norfolk and Waveney, or certainly in Norfolk, are not great. You know, we know that we have a real challenge on our hands, as Paul says, to turn around that tanker. And we're, you know, I think the PAM system is really welcome, because that's like our own assessment. Otherwise, we end up waiting an awful long time for CQC to come back and inspect. You know, any of you who are school governors will know that feeling when you've turned your school around and you're waiting for that to be confirmed. So a really vital area. So comments, questions for Paul? James.
Yes, thank you very much again, and thanks for the report. Are you well received when going into care homes? I'd like to think you are the inquiring friend rather than the critical friend, which other inspectors could be deemed to be seen to be. So I'd love to see this as something that is welcomed by the homes rather than another inspection. So can you confirm that that is the case? Thank you.
Yeah, no, thank you, James. That's a really, really good question. And I think that depends very much on the home. I think that for those who are used to the system now, very mature and very experienced, they see this as a positive thing. They see it as a sense check on the work that they're doing. We give praise where due, and we offer our help and advice to those who we think we could probably do. Then they go, yes, it's well received. I think for those homes who are struggling and have been struggling for some time, we are often seen as the headmaster walking in again to beat somebody with a stick. And whilst we do everything we can to try and make sure that's not the case, there is a role for us to have the right additional scrutiny here. And of course, on a risk-based approach, those who are really good or outstanding will receive less of us, and those who are poorly performing and really struggling will see more of us. And some homes are really receptive of this, and it's encouraging to see. And I've seen the improvements in that area. I was due to go out to a home tomorrow, which I've just cancelled for other reasons. But when we go out to these homes, some of them are seeing this as a helpful tool, so it's good. And we give the adequate praise and support and offer them as much help as we possibly can to get them to turn around. Some, unfortunately, as you know, are beyond help, and we need to take appropriate action in that right area, sensitively, of course.
Could I just come back on that,
Yep,
Chair? In
please
as much as in your presentation, you did say about using the outstanding care homes to help and give support to those others. Obviously, it's a competitive market, is it not?
It is.
The vast majority. So, is that forthcoming?
Yeah, absolutely. I thought it wouldn't be, but it is. I think the end of the day, more residents means more income. And if you've got a restriction on the amount of people you can have coming into your home, you will do everything you can, even take advice from other care homes who've managed to get there, if that makes sense. So yes, it is. It does work.
Thank you very much indeed. Thank you.
Emily, I think you wanted to come in.
Naomi, sorry. Yep.
Oh, hi. Sorry. Hi. Well, thank you ever so much for that presentation. It's really helpful, and I think certainly an area we get a lot of feedback as the LMC from practices is around the high staff turnover, and they often build good relationships with existing staff members, and then those staff leave, and often those coming in have not had experience from care homes and do seem to often like to change processes that have been established and worked up with previous members of staff, which causes an awful lot of work for practices, and also they find it often generates an awful lot more work for where they've agreed how to do something, and then that changes. They find the requests they're getting from the homes are increasing a lot. So I just wondered if that was something that was considered within your visits to the care homes, and any advice and sharing of ideas of how to retain staff, and also to ensure staff are appropriately trained and really understand what the role is of the care home. There does seem to be quite a grey area around what responsibilities sit with the care home in the delivery of care to their residents versus what is the responsibility of their GP practice to be engaged in, and quite often they don't align, and this does result in an awful lot of requests of general practice, which, as you can imagine, having to go out to care homes is a huge workload, and often involves going for one reason and then getting the age-old question of, oh, while you're here, can you just look at this, that and the other thing? So it's really around embedding processes and practices and engaging with the other providers that are seeing these patients, but also on staff retention and training really do seem areas that do need focus and improvement.
Yeah, I think there's a load of questions and relevant points in there, Joe, Naomi, you've been mentioned. Sorry, and I think the one thing that's really not clear, I think, in lots of providers, and this is something for us to think about as our model going forward. You know, we talk about, so for example, I get questions all the time from the community nursing teams. Why am I going into a nursing home to perform nursing duties when there's a nurse there? And you think, well, that is that a relevant question? But that's one nurse often looking after 40 or 50 people. It's impossible to do that. So we've and you're right about the surgeries, primary care being asked to do other stuff when actually is that their role, etc. There's a whole model of conversation which we need to have, and to be really clear on what is the bare standards and basic standards and bare minimum we should be doing. And when we do go out, we do find often that we have to be clear about your Bible, as you're referring to, is the enhanced care and health care framework. That's your standard that you should be set to as a bare minimum. And often that is news to some of the providers. At the end of the day, they are private businesses. They will look at every potential way of cutting costs. However, what's difficult is we have often no way of controlling how many providers come onto the market, which then puts more pressure on primary care. Primary care has to extend their business even further. They haven't got the resources to do that. And I think you've hit the nail on the head in terms of we need to be really clear, working with the local authority, what is our model, what is our maximum, what is our minimum going forward. And that's one of the areas I'm really keen to progress, because all those things you talked about, the workforce pressures, etc., are right in there with what we currently have across the whole system anyway. So I agree with you. Thank you.
That's really helpful, thank you. And obviously, if you'd like to discuss any of these points with the LMC, please do get in contact and we can help liaise from the other side of the providers.
Well, thank you.
Really helpful, Naomi. Thank you, James.
Yes, sorry to come back, Chair, but on that, is this because care homes are now becoming nursing homes, or nursing homes are doing more complicated and doing more complicated work? Is that part of the conundrum?
It is part of it. I think it's more nursing homes becoming care homes. Deregistering is also putting additional pressure, because they also can't provide the funding. They are looking at every way possible to cut costs. And as an example of that, James, which may help, is hourly almost I'm having conversations with clinical advisors, hourly arguing over 200 quid over a patient, which seems madness. But the alternative is, well, I'll keep that patient in the hospital longer, because we can't afford to pay more. They can't afford to take less, but the hospital backs up, and the hospital come under pressure. So these are hourly conversations that are going on where they're trying to save money and cutting costs in every possible area as well to make sure they're viable as a business. So it's that challenge that happens all the time. So there's lots of reasons why, but mostly it's because of the deregistering from nursing.
Yeah, so sorry, Chair, if I may just follow that up. So if you're deregulating or registering from nursing home to care home, you are therefore not required to do the nursing part, and therefore that I would imagine comes into the primary care, and you'll ask the primary
That's
care to come and
correct.
do it.
You're
Therefore,
correct.
also care homes are being expected to do a lot more of that nursing. So there is this huge conundrum that actually needs sorting out, as you've said, to be able to clearly define what each role is. Thank you,
That's
Chair,
right.
very much. Thanks.
And that you're spot on, and that's the whole model we need to talk about going forward. So, for example, the workforce challenges that the community organisations have are not the workforce challenges of the community; they're the workforce challenges of the system, and that's what we need to understand in more detail.
Yeah, I think that's helpful. And just I'm sure you're going to come back to the rest of your slides, but I just to also explain that we've got now a multi-agency board looking at the improvements that we can bring to the care sector more, because they are the reasons why that go into the quality of care are many and varied. And they can't be solved by one single part of the system. So actually that whole system approach is really important, and the sort of the primary care element of that. I think I made a note to myself to go away and just ask myself the question about how that is being fed into that board, actually. So that might be helpful. Paul, did you want to come back to the remainder of your slides?
I could do. I was just briefly going to talk about the next steps.
Fine.
In terms of where we are. So we are targeting falls as a priority. I know that place-based leaders are also doing this as well. We just need to make sure we're really joined up. The priority is around urgent and emergency care, which is basically, well, unscheduled care is the focus. Reducing the impact on all the acutes by admission, reducing the impact on East and sending out admissions, and of course, making sure we have the right framework in place for digital training, technology, supporting people to live a healthy, happy home environment in that care area. And there's a whole new piece of work that's focusing on that to make sure that we are in a better place for the winter this year. I have a small team of 4 wonderful ladies who are involved in the Quality Improvement Network, who work very close to the County Council. We are a finite resource, but we do our best to make sure that we keep as many people as home. And I think some of the work that we've highlighted in the slideshow, which you're welcome to go and look at, has proven that when we get it right, it can and does work. So I'm looking forward to the next rendition of that. Thank you.
Okay, that's brilliant. Thank you. Anything else anybody wanted to comment or ask of Paul?
Lovely.
That's brilliant. Well, thank you very much. I do think it's really helpful to have, a view of some of these other parts of the system, and because it's about the interactions and the interface between different parts of the system that are so critical. So that's been really helpful. Thank you very much.
Thank you, Debbie. Thank you, everybody.
Okay. So I think then we're moving on to service development. So so we've got a couple of CQC inspection reports. So Sadie, are you taking us through these or someone else?
We Shepherd, Debbie.
Excellent, Shepherd. Thank you. Okay.
Thank you, Debbie. Good afternoon, everyone. We have received 2 CQC reports since our last meeting, and that is for Beacon Road Medical Practice and Tyram Surgery. Both practices are under one management team, so I intend to speak on both practices at the same time rather than separately. So both practices were rated as inadequate and placed in special measures back in October last year, and they've since been reviewed again. A comprehensive CQC visit was conducted in April this year. And I'm really pleased that both practices have managed to work with the ICB and improved their overall rating from inadequate and requires improvements. The practices have successfully maintained their good rating in the caring domain, which is really good. and one of them has also significantly improved in their ability to respond to people's needs, that is Beacon Road. So they've got a good rating in that. Action plans remain in place for both practices for further improvements around the safe, effective and well-led domain. Just to highlight some of the improvements that have been observed, their recruitment has been really successful, and the leadership continues to be strengthened. The monitoring and oversight is also strengthened. Just to also highlight some of the areas that we continue to work around the access to care and treatment in a timely manner, which is part of our wider ambition to improve across our system, and they're not insular to that. And also, we're looking to continue to monitor and improve on the annual health checks for people with learning disabilities for those practices, again, as well as the cervical cancer screening and the general NHS health checks for the local population for those colleagues. I'll stop there and check in with whether there are any kind of reactions or comments from the members.
Anybody wanted to come in? Karen.
Thank you, Chair. Thank you, Shepherd. Really good reports. I'm really pleasing to see the improvement. I guess for me, it's about the sustainability and the level of confidence, because we'll often see this where practices and other providers, broader providers, make that progress, but it's about embedding and sustaining. So do you have a view on how that will be managed? Thank you.
Thank you, Karen. So both practices received quite intensive support from the ICB or from the MDT, and that intensive support is going to be reduced to on monthly basis, which is and that will continue for a while. And I don't foresee any challenges in our support for the practices. And also, we are doing some work around the access improvement plans, which forms the wider strategic ambition for us in terms of improving access. And that and the issues have also been identified as part of the PCN access improvement plan. So it's going to be about bringing everything that we have in the system to support those practices. So it's going to be ongoing work to strengthen the resilience that we need for effective delivery of services.
That's good, thank you. Anybody else wanted to comment or say anything or ask Shepherd anything about these? No, that's good. So as Karen said, really good to see that turnaround in those two. That's really good. So I think we're being asked to note those. So I think we can say we have noted those. Brilliant. Okay, that's good. So that then takes us on to item 8. And I think Catherine is going to take us through the item we've got here. Is that right?
Certainly am, Debbie. Thank you very much. Hi, everyone. Thanks for this. I'm Catherine Alter from the Primary Care Estates team, and this is an advice note on sale and leaseback, which we're asking for your approval of. Some of you will remember you previously saw a much shorter version of this advice note, and this is for practices who are seeking to go through a sale and leaseback transaction. So it would be practices who own their premises and are wanting to sale and then lease it back from a new landlord. The previous advice note was very short, but we've had some experience now of working with practices, and it was thought a stage-by-stage approach, as you'll see set out in the new advice note, which follows the primary care premises form guidance, would be more helpful. So what it's designed to do is to try and be helpful to practices and streamline the approach, but we're trying to make clear as well that the estates team are happy to pick up queries from practices throughout the process. It's important because the estates team are not solicitors and we're not chartered surveyors, that practices get independent professional advice from their solicitors or from valuers. I wasn't going to go into what sale and leaseback is, but I can answer any questions and I welcome any comments. If PCCC chose to approve, this advice note will be adopted and shared with practices who are in the process already, with guidance about which stage they'd reach. We wouldn't be applying it retrospectively and sending everyone back to the beginning. And it will also be with shared with practices who raise queries about this as an approach. So welcome comments, welcome questions. I wasn't going to go into the detail of what sale and leaseback is, but I can do that if that would be helpful. But we are seeking your approval, please.
I just wonder, Catherine, before we bring anybody in, if I'm reading this right, fundamentally this isn't a change, but it's expanded and gives more detailed guidance. Is that right?
That's correct. So we aren't changing our policy or approach to this. We're trying to make it clearer by giving it a more staged approach.
Okay. Okay. Anybody want to ask Catherine anything about this or make any comments about this? Karen.
I have to stop putting my hand up. Catherine, I think this is really helpful. I think it really clearly articulates, as you say, the stages, and I think it's really clear guidance. It doesn't overtake any legal, but I just wondered whether the LMC had any comments. I think it's very helpful having the guidance expanded, particularly for me as well.
I don't know if anyone from the LMC is here, but we were very grateful. Joni is wonderful with us in commenting on all things estates, and she has been through the revised advice note and my cover paper. So the LMC have seen it, Karen, and were happy with it, and did change it as well. So that was good. It's worth saying as well, I'm glad you think it's clear and helpful, but we will also always be open to feedback. So as we start using it with practices, if something needs refining, then we will do that. So it's not going to sit on the shelf and gather dust, as it were, gather virtual dust. It'll be kept fresh.
Okay. Anybody else want to comment on this? No, I think you've convinced us, Catherine. I think the detail is really good. So, are we happy and content to approve this as a really sort of practical step forward in this area? I'm hoping I can see nods from the right people. Yes, excellent, good. Okay, thank you very much. That's really
helpful. Thank you.
Okay, so that takes us to item 9, which is the operational delivery report. Who am I handing to, Sadie? Is this one you?
Debbie. Mark, would you like me to do it?
I'm happy to make a start, Sadie, and then I think I'd value your input to follow. But yeah, and my apologies, I'll need to leave at 2:30 as well because I have a clash chair. So my apologies for coming here for this and then disappearing. Sadie, thank you for the report as well. We had our first operational delivery group general practice operational delivery group meeting last week or the week before. They all merged into one, but actually, so it was a bit of an opportunity to really focus in on the kind of key aspects of the group and what we will be looking to focus on. They're a good meeting, very positive, good engagement. We reviewed terms of reference, and the report gives a good overview of the topics that we covered. I think the key bit for me is that this does give us an opportunity to get through into some of that operational detail that we don't always get the opportunity to here, and rightly so at PCC. This is the strategic group. A positive meeting. I'm looking forward to bringing further updates. There weren't any escalations from the first meeting, given that it was the first meeting. I think was a large part of that. But I have high hopes for this group. I think it will really support the work that we are doing. The membership feels right, and yeah, I think it will be good, and we look forward to bringing reports in future. But Sadie, was there anything in particular you would like to raise?
Not in terms of the content. Thanks, Mark, but I would just like to check in with members. We have used the same report that the committees provide to board, as the template for this, and it would be really helpful, given that this is the first one that we've done, if members have any feedback about the level of detail in the report, or whether it's not quite working, or indeed if it's okay. That would be really helpful, because we can of course build on that for future versions. Thank you.
Thanks, Sadie. Hein.
Thank you, Debbie. And I'm off camera because I have issues with my device, so sorry for that. I like the report. I do have a request to see a bit more specificity. Maybe this has to do with the art of letting go, which used to be in the line of sight and no longer is. But if I pick a topic like learning disability, we're getting used to seeing a lot of detail and data, and I think it would help provide some color to what was discussed. I also think it's a good idea to see which members attended, because I think it's important. Good attendance make for good meetings, I think, in this type of context. So a confirmation of that. And then lastly, I think in future operational meetings, also the practices at risk will be discussed. So there may be a need for a sort of part 1 and part 2 report, but that is maybe something Sadie and Mark can give some thought to. But pleased to see this format, and pleased you kicked these types of meetings off. Thanks.
Thank you, Hein. That's really helpful. We'll certainly action those points.
Okay. Did the balance of the things that you were looking at, did that feel about right? I'm conscious of the discussion we had right at the start about the forward programme. Do you feel that we've got it about right? Mark?
Yeah, so if I can come in, it did for a first meeting, but you know, the caveat is that it was the first meeting, and it was as much around setting off on the right foot, for the want of a better phrase. I think meeting 2, 3 will probably be. I'd welcome the question again beyond those meetings, just to check. And as Sadie said, really helpful feedback, Hein. We'll make sure that we action those, because it will be a balance, and we'll need to test this, I'd suggest, over the coming months, that we get the balance right for members here and for that group too. So thank you.
Thank you, Mark. So I guess just to sort of roll back a bit, the idea of this was to allow this committee to be able to give a good amount of time to the bigger sort of strategic issues, and to allow a delivery group to look at the more operational ones. So it will be good to keep an eye on that balance and think about those bigger strategic items we wanted to bring here, like the one we've had today on the Care Quality Commission. It's those sorts of things that I think we could make a difference in, isn't it? So that's great. Okay. So I don't think there's anything for us to agree in this one, because there are no escalations. So it's to note with those helpful comments. Thank you. Excellent. Okay. So now we come to the money. So up to 10, aren't we? Doing well. Okay. And I'm handing over here to James.
That's right. Thank you, Debbie. So as usual in the finance update, I'll treat the report as read, but just point out the key updates for this month. So starting with the exec summary, as we've moved into month 3 of the 23-24 financial year, the ICB is currently forecasting an overspend of 4.5 million across both the prescribing, primary care and delegated areas for the full year. As reported last month, there are unidentified efficiencies within the primary care directorate, leading to some of this overspend. The overall efficiency target is still 5% of the costs, and there's been more work done in July to agree savings to partially cover the unidentified element of this. We'll bring a written update on those schemes in the next month's report for this. The total overspend is broken down on the next slide in the financial summary. This financial summary shows the major drivers behind that overspend. First being within GP prescribing. So we're currently showing £3.4 million overspent. £2 million of that is due to the unidentified efficiencies, and the balance is due to the reduction in the ICB's largest prescribing rebate, which is for edoxaban, and NCSO cost pressures, which we've seen at the beginning of this financial year. The edoxaban rebate has been reduced by approximately 30% for the first 2 quarters of this year. It is expected to return to the higher rebate after that, as regional and national volumes for edoxaban are forecast to go up. Other areas, we're also seeing cost pressures around electricity costs for patients who require oxygen at home, which continues on from last year. And locally enhanced services, we have a £0.6 million overspend, which again is down to unidentified efficiencies at the moment. Within delegated co-commissioning, there's an overspend due to the contractual underfunding, which we've seen in this area from previous years. We have again raised this with NHS England, as we've done in the past, but at the moment no additional funding is available for that. There are some other smaller variances due to unidentified efficiencies in the other areas. The detailed variance analysis shows those major variances discussed with a bit more detail. And then the STF slide, section 4, shows the funding within that particular area. Again, only very small variances against plan for that. Section 5 shows the delegated co-commissioning. Again, the major driver after the PMS GMS offset is those contractual issues I discussed slightly earlier. And then section 6, GP and other prescribing, that's again, as previously described, the edoxaban rebate reduction and identified efficiencies being the major drivers detailed on that page. I'll just talk about another couple of areas that aren't on the written reports. So one is an update on the dental, optom and pharmacy areas. I'll make sure there's a detailed update in the report next month, but there are a few issues which are worth highlighting from a finance perspective at the moment. First being that the patient revenue budget that was set by NHS England on the ICB's behalf for 23-24 at the moment looks too high. From discussions with NHS England, it was set on 19-20 levels of revenue, which is what they expected, but the current level of activity would suggest that's not achievable, and that's therefore causing a cost pressure within there. This will need to be offset against the general reserve that's been budgeted for within dental. Currently, we don't believe this represents a problem, but needs to be considered against future potential dental investments, e.g. the dental emergency pathway and the children's oral health initiative, which have been suggested. The in-year costs for both are currently unknown because they're dependent on the uptake of both of those schemes and then the dental resource that will be available to carry out the service. The other 2 areas, optom and pharmacy, are currently forecast to be on plan at the moment. And then lastly, I'll just an update on the efficiencies and what work's been done recently as well. So we've carried out additional work to identify efficiency schemes for the current unidentified values that were in the budget, which will get our overall efficiency up to the required 5%. A closing the gap exercise was carried out in all areas by directorate to do a full line-by-line budget review. This has yielded some additional savings to this directorate for GP prescribing, expected to be 1.75 million, and other areas of primary care 1.475 million, totaling 3.25. These are in the process of being worked up into full efficiency schemes via PMO colleagues, and we reported back to PRM and EMT. I do, however, need to stress that doesn't solve the financial gap that we have in our accounts at the moment, and we do need to continue to explore every opportunity for savings going forward. And it's highly likely that an additional round of efficiency findings will be needed to help us meet our financial targets. Also, any requirements for further investment in the year will likely require additional governance due to the still challenged financial position. This is especially relevant looking forward to the 24-25 financial year, which will be even more challenged due to the non-recurrent nature of many of the financial mitigations that we've been using so far this year. So that was all I was going to highlight, if there's any questions at all.
So let me see if I've understood that, James. You can test me now. So I think what I heard there was, actually, no worse in terms of last month, but no better. And it sounds as if, some work has started towards finding those efficiencies and they're going to come back. But actually there does appear to be an emerging pressure, particularly around dental services, based on the level of income that was assumed that actually isn't being realised. Yeah,
absolutely. The last point around the dental income is kind of only really recently been realised, and we do need to monitor it and consider that when we're looking at the whole how near plan that is for dental in its entirety. Yeah.
All right. Hein.
Yeah, thanks, James. 2 points. Thanks for adding the commentary that the organization is looking at additional efficiency schemes to address the forecasted shortfall. I think this was a point Bill Board raised in the last meeting, that each directorate should try and sort of manage their own balance, so to speak. So it would be good to sort of see that confirmed in the next report. On the dental side, sort of picking up the point Debbie mentioned, do you know if this is specific to Norfolk and Waveney, or is this a trend across the land?
It's everywhere, absolutely, Heine. And so they set that's the methodology that they used for setting everybody's plan. So NHS England obviously gave us a plan as we started this year, and they used that for all of the patient revenue everywhere. Yeah.
Thank you.
Okay, and then I've got Andrew who wants to come in.
Hi, yeah, thanks, James. I just want to ask a specific question about the dental side of it. In terms of, has the ICB received any guidance on the ring fencing of the dental budget yet?
I don't believe I've seen any written guidance on that. I'm just looking to my colleagues Colin and Stephen if there's anything more that they know, but I don't believe, no.
Just obviously we've had some lip service from the MP about it, saying it's ring fenced, but there's been no guidance about it. The only reason I bring it up is just because it's part of the kind of overall budget, which there's a current variance which might change your overall variance, which if it's ring fenced might need to be separate from that. It's a small point, but I think the dentistry, the reason they wanted ring fenced is so we don't lose any dental budget to something else, which I know there's a huge underspend at the minute. And going back to Hein's point, it is a national problem. The current forecast is that it's about £500 million worth of clawback this year, which is massive. And obviously we know from our own region that it's high here as well. But yeah, just a small point to raise. If I'm honest, going forward, I don't know if you'll ever get any guidance. I think they're probably not going to publish anything, but fingers crossed.
Yeah.
Okay, thank you. Any other questions or comments on that? No. Okay. So just to reiterate then, James, so next time, just tell us again what we can expect to see.
Yeah, so next time I'll add in an additional schedule around the dental optom pharmacy as a discrete schedule at the end, but also an update on those efficiencies as well, the existing ones that were in the plan, and obviously the closing the gap ones as well. We'll add some more detail to that just to keep an eye on those as well.
Okay. All right. So again, this is for noting. So I think we've noted that. We've kicked it a bit, haven't we? Thank you. All right, that's helpful. Okay. So that takes us on then to the prescribing report.
Okay, thanks, Chair. So just my usual prescribing report. Apologies that I didn't manage to field an alternative to myself last month. I thought I'd press send on the memo, but I hadn't. So that was I have been suitably told off about it. So let's not mention it again. Okay, so this is a report on some cost and quality indicators on what is the second biggest spend in the NHS after staff, and the most common intervention in the whole of the NHS, just relating to primary care. So just looking at cost, we generally have been second out of the six new ICBs for some time, and then we have moved to third, and we've sort of vacillated between second and third. This month we are the third highest, which is actually a good position to be in because we do have the highest deprivation score, which would tend to mean that we would normally, if all things being equal, be the highest spend, but it's only by a gnat's whisker are we third this month, but long may that continue. Looking at NCSO, so that's been referred to by James earlier, NCSO, no cheaper stock obtainable, so it's a price concession system that the Department of Health produces when a shortage occurs, which tends to occur because we don't pay as much for medicines in this country as places around the world. So, and it is a global market. So the stock of cheaper products, generic products, is quite limited. And when that runs out, they wholesalers purchase from wherever they can at a higher cost. And that triggers a price concession. This is all quite dull, I'm afraid, but looking at table 1, projected in June was 422k. It's actually projected now at 385k, which is slightly welcome, but the July figure of 175,000 is now projected to be 413,000 price concession, which is very unwelcome, because that's something completely out of our control as such. Cost-effective anticoagulants, as mentioned last time, we're the highest prescribers of the one that we are being asked to use more of, edoxaban, in the country. I did highlight that apixaban is also a cost-effective choice, but the edoxaban rebate system works, which James has alluded to. It's actually based on national market share, so it's quite important that we maintain our use of edoxaban rather than use apixaban. It just means that we'll get a windfall saving on apixaban, an anticoagulant for prevention of strokes. So edoxaban first line is very much the message, because it's not a local rebate scheme, it's a national rebate scheme. Some quality indicators, dependence forming medicines. So we always look at these: high dose opiates, gabapentinoids, and hypnotics and anxiolytics, which are prescribed in primary care. And our performance remains reasonably static. Hypnotics and anxiolytics, which we had been the third highest in the country on, we're now 5th, which is certainly welcome, but still some considerable way to go on improvement on that. And looking at trends, it's all downwards on the whole. Antibiotic prescribing, well, actually coming back to opioids, we did run a session for practice staff on opioid prescribing, deprescribing toolkit locally, which we've been running a project on for some considerable time, and Andy Douglas, who's our GP clinical advisor, ran that session. We had over 90 practice staff on it, and it was well received, and we got some good feedback, so that was good. We're also doing similar training approaches with antibiotic prescribing, which are listed there. Looking at antibiotic prescribing performance, we share the PCN lists, which there isn't huge changes on those overall. I think the plan going forward is to take slightly more granular data to the GP ODG. I think Sadie's suggested that I'd perhaps do that every month, and we can work out more joined up plans of action plans with practices who may be outliers for whatever reason. And we've listed some of those outliers on table 8. Some of those are due to them receiving walk-in patients, the ones at the top, but some aren't. So they are genuine sort of national outliers in terms of volume of prescribing of antibiotics. And then we list also those that are higher than you would expect in terms of broad spectrum antibiotics, which would tend to indicate lack of use of formulary. And all of this data is in the public domain, by the way, before, so that we're not sort of well, we are listing the practices certainly, but as I say, it's available in the public domain. So any comments welcomed? Questions? Thank you very much.
While people are sort of getting their thoughts together, so I guess what I'm interested in is to know, to know whether there is some sort of, both strategy and tactics that you have, Michael, in partnership with primary care and partnership maybe with patients as well, to address some of these areas?
We've over the years, I mean, we've done quite a lot of work on dependence-forming medicines. We won an award a few years ago for our work in Great Yarmouth and Waveney, which was the national outlier, and we did a very much patient-facing campaign on that, which was, you know, anyone can become addicted campaign. So we have involved patients, and we used incentive schemes, you know, targets, setting targets and looking for reductions, did training, and we continue to do this, and our plans look at our priorities each year, and we come up with schemes to focus practices with a little bit of funding and encouragement and some tools to focus on these certain areas. So opioids, for instance, again, we've had some regional funding for some e-learning courses on looking at how you taper patients off of high-dose opioids, and also some training on consultation skills for dealing with chronic pain without going down the route of dependence-forming medicines. And there's a regional strategy on antimicrobial stewardship, and we have regular meetings on that, and we're using those tools and resources and training from those areas. Spend is always an ongoing thing that we work on in kind of yearly cycles in terms of looking at opportunities and implementing those. So there is a very much a strategic approach, but focusing on the areas that need addressing, that are easier to address, whilst also addressing the ones that aren't so easy to address, which are very long-term projects like the dependence-forming medicines. So hopefully that gives you some reassurance that we're working on it, and it's not a quick fix, some of these.
No, absolutely recognise these things are complex, aren't they? Hein.
Thanks, Debbie. Michael, I read that NHS England produced some guidance last week where it says describe 16 national medicine optimization opportunities for the NHS. I'm not asking you to go through each of the 16, but are these opportunities we're already looking into, or are there one or two you said, well, we did not have that on our radar screen, but maybe something for us to look into?
Yeah, they're all things we're working on already, and you know, with our PMO colleagues and finance colleagues, we're working out plans on those that are the easiest to address first. We were behind on so this is high cost drugs, secondary care medicines, hospital medicines, biosimilar eye drugs, but we're actually making some good progress on that one now. So yeah, they're all covered. I have been invited to speak to the National Director of Medicines Efficiency Programmes. So I will catch up with her before our next regional checkpoint with East of England Finance. But there's no great surprises on the list.
No.
No.
Okay, thanks.
Okay.
Karen.
Thanks, Debbie. Michael, really good report. I think what's important to also acknowledge is that we saw an increase in antimicrobial prescribing because of our strep A outbreak.
Yeah.
I think there was a lot of anxiety around a lot of children presenting with scarlet fever or potentially strep A. So it is important to note that's probably pushed some areas of practices that would normally be more compliant into that field of slightly higher rates.
Indeed, because the figures in the bar charts are rolling 12 months, and there was a fair bit of high demand for antibiotics, and quite a few of them went out of stock, as you know, and we had to field alternatives, etc. So that definitely did drive up, and it does continue to drive up the 12-month data because it still includes those high months. Yeah.
Yeah. Okay. Thank you, Karen. That's right. It's helpful to sort of put some of this in context, isn't it, with those sorts of real world situations. So that's really helpful. Thank you. Anybody else want to ask a question or you know, make a comment or anything? How does it feel from a primary care perspective? Any of GP colleagues? Nope, no one. Okay, all right. Okay, well, in that case, then I think we're noting this. A huge amount of detail in there and some fascinating stuff. So, so thank you. Perhaps maybe offline we could perhaps you know, catch up about this, Sadie, and think about whether or not this is another sort of, you know, area that we'd want to look at in a deep dive way. I guess I'm interested to understand, you know, the whether there is, you know, whether this can be an invest to save in some way. You know, if you invest more in actually supporting or challenging or whatever, what that benefit that brings. I'd be interested to know that, but we can follow up outside. Okay. So happy to note that. Good, thank you. Okay, so that brings us to any other business. Sadie, I'm not aware that there is any other business, although we do have, I think it's 2 questions from the public, is that right?
Yes, that's right. And I think people may be here as well, Debbie.
Right.
To ask them in person.
Okay, so so maybe you could help me out on the name, Sadie, and then we can invite. Oh, is that Victoria? Yes, I recognise your name. Welcome, Victoria, and thank you for putting in a question.
Oh, thank you very much indeed, Chair. That's very kind. I've got a question regarding the closure of Blakeney surgery, the Blakeney branch surgery. Advice note 3 regarding branch closures states there should be practice-led consultation and engagement meetings, which vary in times to ensure access for all groups. Holt Medical Practice held a public meeting last week to discuss the potential closure of the branch surgery in Blakeney in the late afternoon. The venue was too small, the time was early for working residents and late for older ones. If travelling by bus, you could get there but not home afterwards. And it conflicted with a pre-scheduled major event in a neighbouring village. And so we estimate about 300 people at least were prevented from attending because of the size of the venue or because of the time and the date. And so we're asking, when will Holt Medical Practice be holding another public meeting? Thank you very much.
Thank you. So I'm probably not expecting a direct answer now, but maybe that's something, Victoria, we could you know, follow up with a written response to you. Is that
yep.
in line with, is that okay? Yeah,
that'd be fine. Yeah.
All right, okay, but thank you for.
Yeah, I think Sadie has my contact details. Well, obviously you have them from the question I sent in, but thank you very much.
Marvellous.
Thank
okay,
you.
well,
Yes, we'll get back to you directly as well, Victoria.
Thank you.
And then forgive me, I can't remember the person that put the second question in, but
there's Alex Hooper, Debbie, who's come on screen.
Brilliant. Okay. Over to you, Alex.
Yeah, hi, thank you. It's also about Holt Medical Practice.
Okay.
And my question is what is the committee going to do to try and ensure that they both identify and engage those stakeholders that need to be part of their patient engagement process? Their current plans seem to rely exclusively on those who either have access to a computer, a mobile phone, or a car, and this seems to be excluding an awful lot of their patients, particularly anyone who has either limited or no access to a car or a mobile phone, a computer, or they have some form of disability.
Yeah, so, thank you for that question, Alex. Okay, so I guess probably, you know, we'll undertake to give you a written response as well to that question, and you know, the issue of broader accessibility is really important, so thank you for raising that.
Okay, thank you.
Okay, so with that, as I say, I don't think, Sadie, we've got anything else. Have I missed anything?
We have Sheilin on screen, and I wonder if Sheilin was also hoping to ask a question.
Okay, brilliant. Sheilin?
I only wish to support the last 2 questions. I am sincerely worried for the elderly in the Blakeney district who have limited access to the surgery. The surgery is no longer in Holt, as I'm sure you realise. It's at High Kelling, which means another bus or a different taxi. And if you have no car or you cannot drive, which happens to a lot of people, you are in serious trouble. You then worry. And when you worry, your neighbours worry or your family worries, and it causes serious problems for the whole area.
Yeah. Okay. Thank you. Thank you.
So please, if you could inform me of your discussions and results, I would be very grateful.
Yep. Very happy to undertake to do that. Okay. Then in that case, I think we'll conclude the meeting. So our next meeting is on the 12th of September at 1:30. So thank you very much, everybody, for your contributions, and we'll see you in September. Thank you.
Thanks very much.
Thank you.
Thank you.